next presentation is by Dr. Jonathan Goldin. He's professor of radiology and biomedical physics at the UCLA, Ronald Reagan UCLA Medical Center, and also co-director of the Thoracic Research Imaging Laboratory. And he's going to talk about advances in HRCT imaging, quantitative HRCT imaging, and IPF trials and the clinical care of patients with IPF. Thank you very much, Dr. Goldin.
Well, thank you very much, and it's a great honor to be invited to be with you all here today. I'll just start off with disclosing that a fair amount of industry work out of our research group, in that we have spun off our own imaging core lab, and, oh, I'm sorry, I jumped already, didn't want to tell you what I do, and a fair amount of consulting with industry, NIH funding for a lot of the work that I'm going to present, and we'll go from there. So, my objective for you is to, I think we've just seen the future of imaging beautifully presented, but I'm going to stay with conventional imaging and talk a little bit about what is going on that is changing what we can do with imaging, and talk a little bit about how we're going beyond the eye and how we are changing the whole approach to dose. So in general, we use HRCT to diagnose a pattern of usual interstitial pneumonia. Scans should be non-contrast. We now know that there should be a certain type of CT. It should be standardized, thin section CT, and there have been recommendations as to how they should be performed. Up until now, actually it's been suggested that all they need to be is full inspiration films taken with non-contiguous axial images, 1 millimeter every skip 10 or 20, reconstructed thin, less than 2 millimeter, with a high reconstruction algorithm, and that you should do some expiratory scans, and where necessary, do prone scans. This is the best we have in the published literature for guidance on how to do the CT. In reality, there's a tremendous amount of heterogeneity that goes on in how scans are done. And I think this has really confounded early diagnosis in the disease. What's been going on in CT is tremendous advances in computer power and computer processing. So there are three things I want to highlight for you that are making a big difference to patient safety and why I think we're about to see a new explosion of how to image the lung. Firstly, we have the higher slice systems. Well, we've gone from having spiral scanners that can take one slice to now you can see there 64, 80, 320, 640 slices all at one time. What does this mean? Tremendous speed. We can acquire a lung in now less than 2 or 3 seconds of breath hold. This is phenomenal for a patient who is breathless lying on a table. Secondly, there's been an explosion on detector technology, how we actually get resolution and the noise within the image. And this is something that's been rapidly changing, and we're right now on the cusp of a major change to photoelectric coils detectors being developed. And across the course of time, this has been a very fundamental change just occurring. The last one is computer power alone, iterative reconstruction. You can see the image at the bottom showing you this image here doesn't look that great to your eye. It's acquired through the chest, but over here is the same picture with computer processing. Over here, after processing, this is what's known as iterative reconstruction, taking a lower dose image and creating an image. It's great news for the patients. It's a little challenging for those of us who've been trying to quantitate what's going on in the lung, because it's a fundamental change in what we're measuring, but that's okay. We'll catch up with it as we go forwards. But these advances in technology now mean that we have CTs that can acquire a chest in less than 2 or 3 seconds. We can acquire a chest with a dose comparable to a chest X-ray. This was never possible, and it's still not widely possible, but I can tell you it's rapidly evolving. So now we have the next thing to do is to improve the resolution, and that will come with detector technology. So some key concepts right now as we talk about imaging is that there's some things we should really focus on. One is image quality. I always tell the story that no matter where I've worked, as soon as I get an image from an outside institution, my report must start with suboptimal imaging from outside institution. We always think our images are the best images and everybody else's is not good enough. But the truth is that for the most cases that I get to do second opinions on, that is the issue. It's the image acquisition protocol. Reading the scan is one aspect, but acquiring a scan properly is really important. So we now know that image quality should be optimized. We really believe that the breath hold should be optimized. You wouldn't do a lung function test without making sure your breath hold was correct. And similarly, for CT scans, you want to make sure that you're acquiring them at a good maximum breath hold and a maximum expiration, TLC and RV. You should definitely acquire some prone images. We now know that they must be thin section, at least less than 2 millimeter, somewhere between 0.6 and 1.25 is the common, although I think you'll see that drop. You can still see we're a long way away from optical tomography, but the reality is that that resolution will drop over the next few years. Another big one is volumetric CT. It's really important to acquire the chest with a full volume at thin section and not axial incremental. Makes a big difference. For example, honeycomb change can look like cyst, but when you can follow the airway all the way out, you'll see it's traction bronchiectasis. You need the volume and contiguous data to do that. We need to use the lowest dose possible. So we need to embrace iterative reconstruction. Even though as a quantitative imager, I've been reluctant to do it because it's a major change to our algorithms, but it is something that we are very fortunate to have come to. Low-dose, high-resolution CT will be revolutionary in the market. The current role of CT is well established, as you just saw. It plays a central role. We as imagers get very excited. There are very few times as a radiologist that I can sometimes say, this is UIP. It's great, it's very exciting, but I can only do it about 50% of the time when the patient has UIP, can I actually get there? So half the time I'm getting it wrong anyway. But the reality is CT plays a very critical role because when it does have the classic pattern as we currently understand it, CT is the end of the story. And eliminates the need for surgical biopsy. It's become very much a part of the multidisciplinary discussion. Probably one of the best things that's happened over the last few years is that pulmonologists, pathologists, and radiologists are talking more together. I'm not sure whether just the simple act of us talking together has made the bigger difference or whether it's all the technology. There are so the purpose of today's talk is to look at what's happening going forwards. Well, there are evolving classifications. We're all very aware that the current classifications are, to some degree, the best that can be done by panels who have got together, and many of those panel representatives you have seen present during this meeting. But we now know that cases that we think were possible UIP, probably from some very nice work by Jonathan Chung and David Lynch, could probably be reclassified into two groups themselves, probable and indeterminate. That in itself is likely to play a role in the evolving classifications, and we are at the brink of some new classifications. Several societies have been working with consensus panels and broadening the literature to do that. More recently, another classification was published by Jim Gruden, looking at trying to classify not only the amount of disease the patient has in respect to interstitial lung disease, but also with respect to the amount of emphysema and other components. So I just show you this to show you that the current way we classify is right now evolving, and I think literally within a year we'll be talking about different classifications. The other role that's evolving is the use of CT and follow-up. I met with a patient earlier this morning who told me that they did not have a follow-up CT, and they wanted to know from me whether I thought they should have. Always a dangerous corridor consult. Yes, your pulmonologist was completely wrong. You should have got that. So I didn't do that. But what I said was, we now have increasing evidence that changes can be seen on CT that may be additive, synergistic, or to the knowledge that we have about the disease progression. And so we now know that this doesn't occur over years. If you look at the textbooks today, the role for CT in follow-up is only if the patient is getting worse or getting worse either for reasons you're not sure about or you think it's the IPF and you want to know maybe how much worse it's got. But it's not used actively in surveillance, and no insurance plans right now will cover it. So it remains controversial what to do in routine practice, but it is increasingly being looked at in patients with unexpected clinical and functional decline and in the patients who have non-definite CT. A lot of patients who don't have a definite CT may have true IPF, and the only way you know is by serial CTs over the course of time. So that's currently where we've seen some evolution, but I think we'll see further evolution of the role of CT. And here you just see an example of a case that has gone, and you can see the very obvious progression between the 2 time points at 12 months. The other role of CT in follow-up is clearly in the setting of an acute exacerbation. But again, like everything in imaging, there's nothing specific on the CT. The findings are ground glass opacities, typically maybe consolidation, the background or changes of IPF, but it's non-specific. But it has a role in helping you. When you've got a certain, you see all of this and you know your patient doesn't have edema, then you know your patient has an acute exacerbation. The other role that CT is being looked at is as a prognostic indicator in the clinic. Right now, as we sit here, different groups from different areas of interest, from physiology through other markers, there's no real good single or combined widely objective measure to assess clinical course and response to therapy. Right now, decline in FVC and single breath transfer are the most common techniques that are used and are very robust and have been very helpful to patient management. And we tend to look at FVC changes of 5 to 10% as being important changes, and they're certainly associated with increased mortality over time. But there are some limitations to pulmonary function testing, and the reproducibility in itself has some challenges, although these things have been dealt with as best they can. The 6-minute walk is very popular in certain settings as another way to provide prognostic information over time. The reality is we're left with some work that was published quite a while back now that as we see a patient at baseline, predicting their change is really not something we're good at doing. Who's going to be a slow progressor versus a rapid progressor versus a patient who's medium and then suddenly becomes worse? This is something that we haven't quite got our hands around, and it's an area that imaging may play a role. The other area is the role of CT to assess treatment response. Certainly, we have a very good way of looking at the structure of the lung, and can we use CT to assess whether changes are progressing, not progressing, or maybe reversing in certain settings. To date, this has usually been an exploratory or a post hoc analysis done visually, the reader looking to see what's better, same, or worse, or the percent involvement, is there 10% now but 5% later? There are some issues with the eye and scoring. There are some superb pulmonologists and radiologists, of which I'm not one, who are really good at scoring their CTs. But the truth is the agreement in score within a reader and across readers is not great. I'm a great believer that somewhere along the line, human evolution required us not to worry about fine quantitation. Our eyes, from work that we've done with UC Santa Barbara, show us that perception is one thing the eye is really good at. So we can perceive danger, and we can quickly assess whether that danger is small danger or really bad danger. How quickly do we need to run? But the reality is how to grade that from a little bit to a lot, we're not that great at it. We can do a little bit, some, more than some, lots, but percentages, really tough. Pathologists and radiologists have really suffered in that kind of area. So computer-based techniques have become another huge area of advancement of CT understanding. We can do things like measure the Hounsfield unit. This is the basic unit of the CT. The CT was actually developed as a densitometer. Tells you how dense, in terms of taking out the beam, the tissue is. And so that's a very good measure. That's the only measure CT can do, although we can convert it into other measures. But looking at the relationship between density, between one pixel, another pixel, mathematically, and at certain factors below, allows what's called texture feature classification. The other advantages that CT have is, funny enough, it's actually easier than spirometry. We do it really badly right now. And the reason why we do it really badly is we tell the patient to get on the table, we switch on an auto voice that is programmed in 5 million different languages, and it very monotonously says, take a breath in, hold it. Meanwhile, the technologist is looking over here, the patient is over there, nobody quite knows where the volume is. I have worked with a UCLA technologist. I've shown them when they look at the patient, when you look at the patient and you tell them what to do and you see what they're doing and they take that breath and then you scan, that's one heck of a better picture than the other way around. So it's really important that you recognize that a good CT is really easy, done very quickly in a shorter breath patient. It allows direct visualization and assessment of the relative components of IPF and superimpose other pathologies, because we know that comorbid disease is such an important component of assessing a patient with IPF. And the extent of involvement correlates with patient survival. Nearly everybody who talks about a scoring system in CT says, my system works because I can tell you that this patient will live longer than this patient. What they're telling you is, if there's a little bit of disease, when they look at you, you do better than a patient who has a lot of disease. That, to me, is not validation of any scoring system. The outcome has been definitely looked at in different ways, and no question, overall extent of fibrosis is a very powerful predictor of mortality. An elevated CT fibrosis score predicts poor prognosis at 6 months follow-up, even in patients who don't have an FVC decline. So now we're beginning to see that there may in fact be, as we advance the role of CT, a role of CT in the follow-up of a patient. Just because the FVC looks reasonably good doesn't mean that there hasn't been some progression that has a huge signal for that patient. So texture feature scoring, if you look at here, you see the different things we look at. We look for fibrosis, we look for ground glass, we look for honeycomb. Actually, what we really need to know is what is normal. I always tell residents and fellows that I work with, they come to me and they're scared because I'm going to ask them about the classification of UIP. Actually, I ask them, what is normal lung? Can you show me the normal lung? Because knowing what is normal is really what we're best at doing. But the computer can measure the histogram feature, that is the density. We can look at the mean, the median, the skewness of it. We can look at gray level co-occurrence matrices as we go further, the contrast, the dissimilarity, the homogeneity of a set of pixels, and then we can get to more complex texture features. All that to be said, the computer can take us below eye perception into seeing things that we can't quite separate out at the eye level. There's lots of quantitative CT. Forgive me if I haven't got all of the groups that are currently active out there doing it. You see some very nice work from National Jewish, who have a very nice system, data-driven. You see the Mayo Clinic with their software, Caliper that was developed. Fluida has a very nice system. You see work from Seoul. And then the green and gold images are from UCLA, from our group, looking at quantitation. What I would say is, it's not a bun fight as to whose quantitation is better than others. What we need is a dashboard of validation. Which software, and maybe it's going to be multiple softwares, but what we need to agree on is how to validate the techniques. So in clinical trials, the use of CT as an efficacy endpoint hasn't really been fully exploited. There are a couple of posters here looking at the role of CT, one in a prospective trial and one in a retrospective analysis as a potential endpoint, but it's still very early. It's definitely very important in clinical trials as a diagnostic inclusion criteria, but I think it has real possibility to become part of the efficacy measure, notwithstanding the limitations of the current methodologies. So I'll share with you some work that we've done that's in the public domain. Here's some work with an anti-CTGF drug with Fibrogen. Here you see quantitative CT being applied. Whoops. Oh my goodness, I'll get it. So here you get, these are drop plots. You're seeing the change in fibrosis. Up would be worsening of fibrosis. Down is potential improvement. We believe that anything within about plus minus 2% is within stable or very mild change. The point being that there was good correlation with the change in fibrosis, and the change in FVC had a very good relationship. And when you stratified your patients who had a decrease in fibrosis, you see that they had a much bigger decrease in FVC. So here we begin to see some role of the technique being used in a drug trial in short term, 6 months and then 12 months. Here you see some other work for a biomarker and validation, looking at the short-term change, predicting who's going to decline more rapidly over time. And so here's some work from Grace Kim from our group, who is the leader of our quantitative group in lung disease. And she's done some very nice work as part of our validation processes to look at the relationship with outcome. And here you see that a change in QLF of a certain percentage at 6 months is highly predictive of slower versus more rapid decliners. In a small cohort, we're not there yet, but this is the kind of validation work that we'd like to see everybody doing. Here's another example of how CT is playing its role in adding to what we know already. So here's GAP, which is a well-known way of doing gender, age, and physiology mapping of how well patients will do. GAP7 don't do so well. GAP3 tend to do well. But what's interesting is if you add change in fibrosis and you stratify and add it to your GAP, suddenly what you see is you can have a person who had a GAP7 to start off with, but actually they do really well if they don't show progression after 6 months. So I think there's evidence growing that a CT's biggest advancement is in the follow-up of patients, adding to what we do already. The other thing is the change of fibrosis. If we look at pulmonary fibrosis endpoints, the most usual one is a decrease in FVC of 10%. And so, does CT add something to it, or is it just a surrogate, or is it just a reinforcer? I don't think we know the answer yet, but what you see here is that once again, predicting what happens over time is increased by knowing what happened to the CT change. So short-term CT change does appear to have a signal, at least in some patients. We need to do bigger studies, and that's what's currently going on. So in summary, I think that the advances in CT start back with the machine. We should not lose sight of the fact that applying a computer algorithm is only as good as the imaging coming in. Garbage in, garbage out. I don't know a lot about computer science, but I'll tell you that that's a true statement. Deep learning and big data sets will be very helpful. I don't think it'll get away from the fact that you have to have some degree of quality control over the images you're looking at. So standardizing the CT acquisition, we should all be doing CTs that are volumetric, thin section, non-contrast, at low dose. We need to use computer vision and deep learning techniques to detect and characterize the disease. And I think we're really seeing some real growth in CT being predictive and a surrogate outcome, both in clinical drug trial, but also just in patient management. So I hope that's giving you some insights into where I think imaging is going. Thank you very much.